Welcome to this presentation on misplaced lines and tubes. We're going to keep it very simple. This is a first version of this talk. We'll probably, in fact, we'll certainly post an update in the future, but for now I just want to get us started. There are basically three types of hardware that I want to talk about: central lines, endotracheal tubes, and nasogastric / feeding tubes. And when you get a radiograph after placement of each of these devices, you need to assess for two things. One, that the tube is in the or the line is in the proper position, and you also need to look for complications. Let's start with proper positioning. So if you have a radiograph, and we're going to concentrate on radiographs of the chest, the proper position for some of these lines is really not that difficult. So an endotracheal tube, obviously it needs to be within the trachea, so that means it's going to be in the midline on a radiograph of the chest. You want it to be above the carina. You don't want it slipping down into the right main bronchus, because that's where it's going to go if it's put in too far. And we'll look at an example of a tube position in the right main bronchus, and we'll look at some of the consequences of being in an abnormal location. Central lines, of course, you want those to be in the SVC, and basically in essentially all cases. And the complication that we're looking for there usually is a pneumothorax. And of course, feeding tubes and nasogastric tubes, you want those to be below the diaphragm. You want them to be in the stomach, or potentially, in the case of feeding tubes, you want those to be in the proximal small bowel. So the complications there are basically related to going into the lung when you're talking about nasogastric tubes and feeding tubes. And we'll look at some of those examples in just a second. So this is an individual who has an endotracheal tube that's appropriately positioned. It's in the midline. The tip, you want it to be just about at the level of the clavicular heads. So this is a well-positioned endotracheal tube. The feeding tube there, you can see that the tip projects below the diaphragm. It's in the stomach, so that's probably okay also. The left subclavian catheter tip is in the superior vena cava, so that's also appropriately located. This person has a steep sulcus sign on the left, so there is a pneumothorax associated with the left-sided central line, but these lines look appropriately positioned. So let's look at some improper positioning and some complications. Here we have a feeding tube, and obviously a feeding tube needs to be down where the feedings would do some good. So this person had a feeding tube placed, and instead of going into the stomach, it went into the right lung. And unfortunately, they started feeding this poor patient, so their lungs started filling up with tube feedings. This is not what we want to see. Another example right here of a feeding tube. This is one that was caught before they started feeding the patient. So if you put any of these devices in, you need to check a radiograph to make sure they're in the proper location. Here we found the feeding tube in the improper location. They pulled it out and repositioned it, and everything was fine. No harm done. Another example, on the left, you can see that they've put this feeding tube in place, and it's gone down the trachea, down the right main bronchus, and down the right lower lobe bronchus, and it's been pushed in so far that it's gone all the way into the pleural space. So when they pulled it out, they ended up with a pneumothorax. And the image there on the right is after they pulled the feeding tube out, and you can see that the patient has a resulting pneumothorax, and that white blob in the right hemithorax is the collapsed right lung. Another example right here of a tube, or rather a line placement. Here they've put in a right PICC line, and remember that you want those lines to go into the superior vena cava, and this line, instead of going into the superior vena cava, goes up into the right neck, so it looks like it's in the right internal jugular vein. Here's another individual that had a left-sided central line placed, a left subclavian catheter. And if you follow that left subclavian catheter, you can see that it goes way, way, way lateral to where you would expect the superior vena cava to be. The right subclavian catheter there is in the proper location. So the right subclavian catheter tip is in the superior vena cava. So that tells you where the superior vena cava is located. But the left-sided tip crosses the midline and goes way off to the right, so this is improperly positioned. And this person ended up getting an arteriogram, I'm sorry, a venogram, superior vena cava gram. SVC is marked there on the image there on the right. I've also marked the catheter tip, and circled is some hemorrhage. So basically what's happening here is that we have perforated the SVC and we've got hemorrhage into the right hemithorax. And that's what all that white stuff is in the right hemithorax. That's all blood. That's a big hemothorax there from having perforated the SVC because of this line malposition. Another example here, this patient had a right internal jugular catheter placed, and you can see that they have a pneumothorax that you can see very well on both of these images, and you can see that it's getting increasingly large, and in fact on the image there on the right you can see that the patient has developed a tension pneumothorax. If you look at the endotracheal tube there on the left, you can see that it goes down into the right main bronchus. The right subclavian catheter and the feeding tube there on the right are appropriately positioned, but the endotracheal tube is down in the right main bronchus. You can actually see the carina in this particular individual. And later on, what happens when you've got only one lung being ventilated? Well, the other lung collapses. So you can see on the image there on the right that the right hemithorax is now completely opacified. The mediastinum is shifted over to that side. That tells you that you have atelectasis of the left lung in this particular individual as a consequence of having an endotracheal tube down in the right main bronchus. And the cure for this is really easy. You just pull the endotracheal tube back several centimeters. Again, you'd like the tip to be projecting between the two clavicular heads, and that would cure the patient's abnormality. These are different patients. Note that the patient there that's on the right has a fracture of the left clavicle. So these are in fact different patients, but this is supposed to illustrate the consequences of a right main stem intubation. Now sometimes you can get in trouble because of the limits of radiography. So this person has two central lines, a right-sided PICC line. This is the same one that went into the right neck. There's a left subclavian catheter. The tip is in the SVC. Look at the tracheostomy tube there. That looks okay. The tip is between the clavicular heads, and it looks like it's in the midline. It looks like it's in the trachea. Let's look at the CT scan. On the CT scan, I've labeled the tracheostomy tube and I've labeled the trachea. And you can see that the tracheostomy tube never goes into the trachea. And obviously, if something's called a tracheostomy tube, you'd like it to be in the trachea. So plain films are limited. We have sort of a two-dimensional view of a three-dimensional object. So sometimes we do have some limitations, but overall they're pretty reasonable for monitoring lines and tubes. But in this case, it sort of let us down. That ends Misplaced Lines and Tubes. Thank you.